Hi, my name is Jody Wolf. I want to welcome you to our webinar, Pediatric Lipid Literacy. I'm going to start with a few housekeeping items. Let's take a look at the screenshot of the attendee interface. You should see something that looks like this on the top of your computer. I'm going to direct your attention to the Q&A at the top of your computer. You will have the opportunities to submit text questions to today's presenters by typing your questions into the Q&A window. To activate the Q&A window, you will need to click on the Q&A icon at the top of the webinar window. The Q&A window will then be brought up and you can type your question in the field labeled, "Please input your question." You may send your questions in at any time during the presentation. And I really want to stress that, that I've talked to the presenters and we really want this to be interactive. And so we're going to answer questions throughout the presentation versus saving them to the end. So feel free to type things in as you're thinking of them. Okay, next slide. At the conclusion of the webinar, you will see a QR code for a brief survey. Please take a few minutes to complete the survey. This helps us on topics for future webinars. Next slide, please. I mentioned earlier to look at the QR code, and you can go ahead and scan that with your phone. We're using a platform called Slido, and we will use this to ask you some polling questions as well as to do some knowledge check. And we hope that this will bring some good engagement with you during the presentation. So you can go ahead and scan that Slido QR code. Next slide, please. And here are the speaker's disclosures. And now we'll jump in and get started with our objectives. In today's session, we'll discuss the basic metabolism of fatty acids and their role in neonatal growth and development. We'll describe the effects of injectable lipid emulsions on fatty acid levels, and we'll summarize the clinical considerations when selecting intravenous lipid emulsions. And to help us accomplish these objectives, we have two experts that I'd like to introduce to you. Camilia Martin, Dr. Martin is a professor of pediatrics and the division chief of neonatology at Weill Cornell Medicine. Dr. Martin received her MD from Weill Cornell Medical College and completed her internship and residency at Lurie Children's Memorial Hospital, Northwestern School of Medicine, where she served as chief pediatric resident. Dr. Martin completed her fellowship in perinatal neonatal medicine at the Harvard Combined Program in Neonatology. During her fellowship training, she completed a master's in epidemiology at Harvard School of Public Health. After fellowship, Dr. Martin spent 20 years at Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, where she was an associate professor of pediatrics at Harvard Medical School and the associate director of the neonatal intensive care unit and director of the cross-disciplinary research partnerships and the division of translational research at Beth Israel Deaconess Medical Center. In May 2022, Dr. Martin assumed the role of the division chief of neonatology at Weill Cornell Medicine. Dr. Martin's research spans from basic to clinical translational research to study neonatal nutrition and its impact on health and disease. Her research program is supported by broad-based funding from the NIH Foundation, industry, philanthropy, and state-level programs. She participates in multi-site cohort studies and clinical trials, serving as the principal investigator evaluating nutrition and growth and long-term neurodevelopmental outcomes in the extremely preterm infant. Her current research focus is lipids and fatty acid metabolism. Dr. Blanco. Dr. Blanco is a professor of pediatrics with tenure and is the division director of neonatology perinatal medicine at UT Health San Antonio. She is the holder of the Greehey Family Foundation Chair in Neonatology Research and the co-director of clinical research for the Clinical Research Center for Neonatal and Childhood Research. She is an active member of the Committee of Nutrition for the Academy of Pediatrics. Dr. Blanco is heavily involved in clinical and translational research. Her research interests are in parenteral and enteral nutrition of the critically ill neonate. She has performed several randomized controlled trials in the critically ill neonate, and her research has involved investigating the effect of intravenous amino acid supplementation in the extremely low birth weight infant. Her clinical research also includes enteral nutrition strategies to decrease the incidence of necrotizing enteral colitis with exclusive human nutrition and the biochemical markers involved in pasteurized human milk and the relationship with gastrointestinal disease. She has done research in fetal and neonatal environmental exposures and the effect of glucose metabolism and insulin signaling pathways. Due to her passion, a neonatal nutrition and bone institute was established under her leadership at UT Health. In this institute, body composition analysis can be performed utilizing DEXA, body air displacement, and ultrasound bone scans. Dr. Blanco believes we can continue to improve the health of neonates, children, and adults by improving nutrition and metabolism at an early age. Dr. Martin and Dr. Blanco, thank you for joining, and now I'll turn it over to you.
Thank you very much, and thank you for those wonderful introductions. Cynthia and I are excited to be here. Welcome to everybody for participating in this. I'm looking forward to it and hope there's some really good engagement. There's two general sections. The first one, we're going to go over general physiology and lipid emulsions. And I want to clarify that this is for the maintenance nutrition. So the preterm infant, and especially within preterm infants. So the preterm infants admitted to the NICU, and how do we approach and start to think about fatty acid metabolism and what we're doing at the bedside. So let's go ahead and go to the first question. So we're going to start off really actively here. We're going to start with some questions, and then we're going to follow with some of the response and what we think would be the best answer and what would be the supporting evidence for that answer. So first question, which statement is most correct regarding fatty acid accretion and levels during fetal development? The transfer of fatty acid depends on the DHA and ARA levels and ratios present in the mother. So DHA, docosahexaenoic acid, ARA, arachidonic acid. DHA is equal to, they're changing based, I think, on the prevalence. Let me make sure. ARA is at least twice higher than DHA in the major tissue compartments. DHA is equal to ARA in the major tissue compartments. And DHA is at least twice higher than ARA in the major tissue compartments. So we want the most correct answer here. I can see that we almost have 100 participants, which is fantastic. So I want to get a quorum, a majority, before we go into the explanation. We're at 30. I know there's more. Don't let what you see as the dominant answer influence what you think might be right. We're all here to learn. Hey, I want to get to 50. So 15 more people.
I think a lot of the times it might depend on how fast you can get that QR code working.
Oh, true, yeah. If there is any difficulties with that, chat and we can help you out. All right, 10 more. It's great though. This is
yes, it's going up. It's going up.
Yeah.
And for those of you that joined a little later, feel free to put ask questions in the chat. We're going to try to make it interactive and answer the questions as we go.
Okay, we're almost there. A few more, and then we're going to move on. So I want to make sure we get to all of our questions. All right, so we're almost at 50. And this is exactly why I love doing these things, is really to sort of educate ourselves about fatty acid metabolism in the preterm infant. And this was asking the question about the fetal compartment and what's happening. And the answer is actually the third one there, which is that ARA is at least twice higher than DHA in the various lipid compartments. And this is really important to think about as we think about what is the role of ARA then? Why is it outpacing that of DHA, especially during fetal development where organogenesis is really an important driver of fetal development? And these are my three favorite slides that illustrate or figures that illustrate these principles. And so on the left is kind of supporting evidence of what we call the biomagnification of these fatty acids selectively for ARA and DHA. This one's an example of a DHA where on the y-axis you have the circulating phospholipids and the percent DHA, mole percent. And then on the x-axis you have gestational age. And it equates, the fetal levels are similar to maternal levels, but as you go into that last trimester, you see that fetal levels even outpace of what was even in the maternal compartment. And this is for very specific placental mechanisms that are in place to really help with this fetal accretion and this biomagnification of fatty acids. And DHA and ARA are both critically important in fetal development. The middle panel really tells us what is the relative balance and ratio these fatty acids are relative to each other. Not only to the maternal compartment, that if you look at, say, let's look at the circulating compartment in the middle where we have maternal ARA at about 6%, DHA at about 2%, you see again that principle of biomagnification where ARA is at least twice that and DHA is also higher than that. But I think what's important, and as we think about in neonatology, where do we want these fetal early neonatal fatty acid levels to be? What are the relative developmental importance of those balance and fatty acid ratios? I think the panel there on the right side of the fetal gives us some of these answers of what might be important. And what you see is in the circulation, we show that the ARA and DHA, you have the DHA at least 2, right? It's almost 3 times higher. You look at the brain, about 2 times higher with the arachidonic acid to DHA. And then in the adipose tissue, you see this reservoir of these fatty acids, and ARA is almost 9 times higher than DHA. We don't go into all of the slides in the physiology and the mechanism, but there's nice animal data to really demonstrate that ARA is a driver of organogenesis. So it makes sense that during this period of fetal development and early neonatal development, that those arachidonic acid stores are going to be very important. On the right is just a reminder that where is the accretion occurring in the tissues, and we think about the brain and the eye and these important tissues, but what you see there in orange is the accretion in the adipose tissue and the fat tissue. This is important to consider because when babies are born preterm, we all know at the bedside, the adipose tissue stores are very small, if existent. And so preterm infants are immediately vulnerable to what we're providing in the maintenance of their fatty acid levels. So the answer there is ARA, twice as high as DHA in these fetal compartments. Okay, next slide. And please monitor the chat and interrupt if there's any questions. Happy to further expand on some of those explanations. Question 2, true or false? Preterm infants have lower fatty acid levels at birth compared to full-term infants. So now we're at a bit over 100 participants. Hopefully everyone is on the Slido site and we get a majority of participation here. And Cynthia, jump right in if you want to add to anything, and I'll do the same.
Absolutely. So far, a great explanation. I always learn every time I'm with you in these talks.
That's great. Likewise. Oh, good. We're definitely moving along. We're at 50 at a much higher pace or swifter pace than last time. Let's see if we can get a little bit higher, and then we'll answer question 2. Okay, seems to be kind of steady at 92 to 8. Again, why I love talking about this. I'm going to say that the best answer here is actually false. The preterm infants don't have lower fatty acid levels, and the important key aspect here in this question was at birth. So let's look at the next slide. And this is one of the first studies I did in lipids and fatty acids, and made me fall in love with the entire subject. But when we look and read our papers, what's going to be important is to understand at what point, what day of life was the fatty acid, that first fatty acid level, drawn. What's amazing is, again, probably because of the lack of adipose tissue, just how swiftly the fatty acids will go into either deficits or an excess. And we'll talk about this. And it's happening by day 7. So if you read some of the papers that do that first level at day 4, day 5, you are going to see a difference in term versus preterm, but it's because of when that level was drawn. In this study, we were able to use sort of core blood values. So we had the birth day of life 0, if not the core we had by day of life 1. So in this study, we made sure that it was either the 0 or 1 day where we measured that initial fatty acid level. And to orient you to the slide, again, the y-axis is the mole percent, the x-axis is the postnatal week. And then on the left for the DHA, we also sampled term infants. And so you see the 2 blue dots. The level for term and preterm are essentially the same, 7.5 mole percent. And then by 7 days, you drop. If you go to the right on arachidonic acid reflected in green, here the preterm infants slightly higher than term infants, but relatively in that margin of 15 versus 17. And then the linoleic acid in yellow, you see pretty much the same again, 7 versus 8%. And so the levels are approximating each other at birth. What distinguishes them later in their fatty acid profiles is that immediate change by week 1, because I think partly due to our nutritional practices, partly due to the absence of those adipose tissues or those reservoirs for those important lipid mediators.
In regards to this, Cami, can you clarify, like especially in the graph on the right, were these preterm babies like late preterms, very low birth weight preterms and receiving a lot of IV lipid solutions, or were they predominantly like enterally fed? I think that's just always helpful. I know that you don't have enough time to go into you could go for another hour talking about that subject, but.
No, great points. This is a cohort of infants. It was a total of 88. Less than 30 weeks of gestation. So they were receiving lipid emulsions in addition to sort of advancing and slowly advancing their enteral feedings. At the time here in this study, intralipid was the lipid of choice. I'll tell you that some of these patterns are consistent in general across these lipid emulsions, so we will talk about that. And so so that first week, that day 1, they're going to be predominantly or a majority receiving the lipid emulsion relative to the enteral feedings. But what's interesting, and a point to pull out, because I don't know if we necessarily pull it out later, is that if you go week 2, week 3, week 4, once these deficit occurs, even as they transition to full enteral feedings and breast milk feedings, you don't really see much of a catch up in some of those deficits. And so for me, what I think is really important is really paying attention to what our practices are doing. How can we correct this situation? We know it's biologically important. It's really a question during those first 7 to 14 days. Thank you, Cynthia.
Thank you.
All right, next slide. So if you listened, you have this answer. So compared to birth levels, because we're going to go back to that figure, in preterm infants at 1 week of age, fatty acid levels are the same. All of the fatty acid levels decline. We show an increase in LA and ARA, while EPA and DHA decline. They move the options as you guys come in, so I have to keep track of what I did say or did not say. LA increases, EPA does not change, DHA and ARA decrease. I think I read all the 4 options, and yeah, let's see what you think.
You see, I was trying to help everybody.
That's right. So the answer was in that prior slide. Great, great. We'll get to our magical 50 to 60 responses. All right. I think it's settling out to this proportion, and you guys did a great job. Yes. LA increases. EPA does not change. That part we hadn't shown yet. And DHA and ARA decrease. So let's go back to those figures in the next slide. And so the DHA, we don't provide this. We don't, at least in this study, and we'll talk about what it means to provide it later in different lipid emulsions. But the reservoir is not there. Approximating that fetal accretion rate is really challenging after the babies are born, the preterm babies are born. The DHA and ARA does go into deficit. Our diets, even breast milk, but our diets and enteral diets and intralipid emulsions that are lipid emulsions that are using a base of soybean oil will have linoleic acid in it. And so there's a tripling of the linoleic acid that you see that's occurring by 7 days. And so this kind of reflects, again, not only the inability to maintain that fetal accretion, but the diets that we are providing. And so that tripling does occur with the LA. I'm going to show you a little bit later in some studies with EPA, but EPA actually does not change much. It's not really a selected fetal accretion fatty acid in utero. And then looking longitudinally in this study and all the other fatty acids, EPA had a relatively unchanged in the overall mole percent from birth out to 1, 2, 3, and 4 weeks of age.
Yeah, and I think as you go through, there was a question by our friend, Dr. Prem Kumar from Baylor College of Medicine. I saw it right there about the intralipid emulsion practice, right? As it has evolved from the original studies, how are those trends, similar or different today?
Yeah, so we can, for intralipid, I think this is what you're going to see. If we're using intralipid, these are the patterns that you're going to see. I think even then at this study, what our practices were at the unit at the time is we would start at 1 to 1.5 grams per kilo per day. We were advancing by 1 to get to 3 grams per kilo per day. So by day 3, definitely by week 1, you're on full lipid emulsions at 3 grams per kilo per day. We are, Morley, if you wait a little bit longer, we're going to talk about some of the other studies and what these fatty acids do with the differing lipid emulsion options that are now available to us in the NICUs. All right. Next question. This slide, actually, I think maybe the next couple of slides, I just want to mention that these patterns we've known for a while, and they're very consistent. I wanted to reinforce that the study I was highlighting isn't a one-off. It isn't something that was sort of unique to that one site. It is patterns that we see repeatedly in the literature. And this was one of the first studies that I recall seeing. I believe it was in 1992, Allison Leaf, where you see these patterns. You see, and here there was a little differing nutritional practices because it was a while ago, but in general, you're seeing these early deficits in DHA and ARA. You're seeing LA having that tripling of elevation. And what's fascinating, just to step back, is as we look at these patterns, what we're doing is these absolute levels and the balance that they are relative to each other are completely reversed to what they've been seeing in fetal development. So it's not a surprise that we do see in some studies that these fatty acid balances and levels do play a role in overall development in morbidities. So this is just to illustrate that this pattern is not unique to one study, two studies. You see it over and over again. And so the next slide is a demonstration of that. I was going through all the literature and seeing, what were people describing, and you see the same pattern, ARA, DHA, by 7 days, you show that initial decline, then it's kind of steady throughout the rest of the duration of the NICU stay or duration of the monitoring period. And these were 3 different studies that evaluated this and showed those same patterns. So have these patterns in mind as you think about the clinical questions and the research questions on the relevance of what we see here. Okay, next question. So let's rank the lipid emulsions from highest to lowest in the soybean oil content. So we have 4 lipid emulsions we'll be speaking on. 100% soybean oil, so that's called soy oil intralipid emulsion. A 4-oil lipid emulsion, so a mixed olive and soy oil, and then 100% fish oil. So thinking about the soybean oil content, how would you rank it from highest to lowest?
And I'm sure you're going to go through this, but as we are waiting for more questions, the importance of having the different omega-3, 6, and 9 combination, and how does that really translate into the levels of free fatty acids that we want? And do we know much about what is, we know the fetal levels. Do we know how does that translate into, short-term and long-term health on the babies?
Right. I think those are 2 ongoing questions, right, that we're all trying to figure out is we understand where the birth levels are now, I believe. We've got good fetal data. We've got good early data. And can you replicate that fetal accretion? Starting to think maybe not. That's a pretty rapid sort of biologically programmed accretion in this protected environment. Probably not. But how much do we have to approximate that to actually see the benefits of the health outcomes, both short and long term? And we got to consider various other situations that might change where we want that balance to be. And in general, I tell people what you feed, you end up seeing it. But there's a few surprises, I thought, as I was learning about lipids, about how these fatty acids are induced by the different lipid emulsions. And we will go into that a little bit. All right, I think we're at 50. And so let's talk about, so the top 2, everyone was very clear, soybean, 100% soybean oil. That's obviously the highest. Fish oil, 100% fish oil, obviously no soybean oil. That's the lowest. So everyone got there. And it's just does the 4-oil versus the olive oil. So let's look at some composition slides to help us decide on that. And so in this slide on the top, you have the different lipid emulsions and the relative percents of the soybean. So the top row actually tells you that answer. And so with the mixed oil, the far right, it's a 30% soybean oil content. And on the second column, you have a 20% soybean content in the olive oil, fish oil. So as a percent in content, you see that the ranking would have been soybean was greater than the fore oil, which was greater than the olive oil, which is greater than the 100% fish oil. And why do we talk about soybean? Because that, I think, is what's causing the linoleic acid rise that we see. And in that clinical data, the LA ratio, when looked at relative to the DHA ratio, had an increase in the risk of lung injury. So that is probably something we want to sort of try to tampen on a bit, not have such a high increase in LA relative to these other fatty acids. So using ultimately a lipid emulsion or a strategy that brings that down a little bit is something to consider when we're talking about future uses and future and lipid emulsions. So this slide gives you that composition. And here's just another slide that basically shows the same thing with also the FDA approval status. And to be clear, the soybean oil, the olive oil, and the 4-mixed oil all now have FDA approval status for both adults and pediatrics. And omegavin, which I'm sorry, 100% fish oil, which we're going to talk about later, is it's kind of a special indication of use. So remember, up to this point, we're really talking about maintenance use and maintenance lipid emulsion. So you see the fractions of soybean oil in this slide as well. This no necessarily right answer. I think all of us as clinicians might have our go-to when we're in the NICU. And this is just to get a sense of what's happening out there. So share with us sort of what lipid emulsion do you use as your first line maintenance for preterm infants? So a brand new preterm infant, say less than 1,500 grams, so likely to be put on parenteral nutrition. You're writing your orders for your PN and lipid emulsion. What lipid emulsion are you ordering?
Yeah, and I think like this question, it's very important for all of us that do research and participate in clinical trials. As a matter of fact, I'm going to pitch in like something that's going to hopefully come out in the next few years. Cami Martin is leading with Sarah Taylor, and we're participating with her on a prospective clinical study where we're like measuring all these levels, right? And I think like translating into clinical practice is very important because we're going to learn a lot about free fatty acid metabolism and what happens, but we need to know what people are using out there in order for us to translate our findings to the rest of the country.
Yeah, no, absolutely. And I think it's important too to understand, it gives us an idea of where's everyone's mind is clinically and what they think and the decisions they're making, because those may be the questions that we need to answer and understand as we continue to iterate and advance in this field. And I think we have made some advancements over time and knowledge, but we've got a long way to go. So I think this is kind of in general, Cynthia, what do you think? This is kind of my impression as well, that it's still kind of dominated by the first two in the 4 oil lipid emulsions and the soybean oil. I do think when the 4 oil lipid emulsion came out, it started to pick up some nice pace in its use. My understanding, but put it in the chat. Let's record some thoughts about what was that impetus to change over. I think my understanding is the thought that you're providing other fatty acids and you're providing a DHA, which we know is very important. But we'll talk about what it does to lipid emulsions and how we should thinking about the use of lipid emulsions that have fish oil in it. And so, yeah, I think this kind of reflects accurately what I hear from others
Yeah.
as well.
And it is important to remind everybody, right? There's so many other components of the lipid emulsions that you have to take into account. A lot of the thought process and the phytosterols, but then at the same time, there's a lot of unknowns about like the amount of, vitamin E, all the different types of beta tocopherol. How is that going to affect baby's health, right? So
Yeah.
I think it is important to think, is this really something, what is A, B, C, or D, the most important part of the component? Are they all important? And is it the same for all, right?
Yeah.
Is it the same for a baby who's born at 500 grams versus a term baby born with gastroschisis, right?
Yes. No, absolutely. I think that's a great point. And we continue to learn. And I think we need to continue to challenge ourselves, because here we're talking about maintenance, but what about the older late term infant? What about a surgical condition? What about prolonged PN use and lipid use? Where do we want that balance to be based on the underlying conditions? All of those, I think we need to seriously think about in advance in our understanding. And we're going to talk a little bit, yes, the other compositions. This is a fatty acid, largely a fatty acid discussion. We're going to go into a few other things, but there's so much more that is in a lipid emulsion that I think is open to further study, and we should do that. All right, next slide. So the 4-oil lipid emulsion, which has gained some traction, has been shown to be superior to soybean oil lipid emulsion for the maintenance delivery in the preterm infant. And superior, like in what context? We'll talk about that. That could be a little bit vague.
That was going to be my questions. What do you mean with superior?
Right. I was like, huh. And I do think about that in two ways for those that have heard me speak before. Are we talking how we're approximating fatty acid levels? Are we talking about short and long-term morbidities? I'll tell you, this question is set up about the morbidities and health outcomes, but we'll talk about the fatty acid changes as well. So good. I think we're going to settle on 2/3 false and 1/3 true, and that's right. It is false. And again, conceptually, I can understand the enthusiasm of having a lipid emulsion that has multiple components, starting to add stuff that we know that you need. But interestingly, there is no change in our morbidity outcomes. You will look at some single center randomized trials, smaller or pre-post, so the literature can seem mixed, but when you're looking at all of them in a meta-analysis, so if we go to the next slide, a meta-analysis of these lipid emulsions in this latest review, and I'm sure it'll be constantly updated as Cochrane usually does, there was no benefit found for any particular lipid emulsion, with or without fish oil, to be better than the next. And I bring this up because often it is the fear of what Intralipid has, this whole thought of the LA and the soybean, immediately sort of connecting omega-6s to inflammation, which is not fully true. We talked about the role of that in organogenesis. So I think there's this general thought that it must be better health-wise and that we would see this in benefits and short and long-term outcomes, but we just have not. We have not seen that benefit in moving away from 100% soybean lipid emulsion. And we'll talk about then, what does it do to fatty acids? What about the other question then? What does it do to fatty acid balance? So we can go to the next slide. So speaking of fatty acid balances, so when 4-oil lipid emulsion is used compared to soybean oil, what do we see? Do we see a decrease in the LA? Do we see an increase in the DHA? Do we see a decrease in the ARA? None of those are true. All of them are true.
These are the questions that I call Cami challenges.
It back to
You have
good
to
old
really think
SAT
about it and
questions,
focus.
or the MCATs, right?
Yes,
Yeah.
yes.
B and D, but not C. Yes. Right. Usually, not, although not always true. When you see a none or an all, you kind of gravitate to that.
Yeah, but I think it's also like, this is why we're doing this. It's very important to remember about all of the other factors, right? It's not just DHA, or it's not just AIA, or it's not EPA. So, as we also read the literature on supplements, right, and other approaches, where we think about like we're supplementing one, but we're not supplementing the other, and providing that ratio and that support system that you need, to not be scared of asking the question, right? Like, so the outcome that we were trying to find did not, turn out to be the one we thought, but then we need to learn more about the interactions with other free fatty acids. The same thing as we do with like protein supplementation and many other things that we add on. We really need to understand more the biochemical effects of all these interactions.
Yeah, no, absolutely. Interactions that balance to each other, system biology. We're really learning, I think, that lesson throughout all of our work, even in human milk biology. And we've seen over and over, as we replace one or concentrate on one factor and you don't see the effect, you see that there could be, and you wonder why. Well, we're removing it from that systems biology impact. And so this is not unlike those other fields where we have to think of it more about an ecosystem as we iterate forward. So I think we've settled out to all of the above, and that is correct. So let's go into a couple of studies, and this, Morley, may help answer your question about what is happening to the fatty acids with these other lipid emulsions. This is a preterm piglet study, and then I am going to show you a human infant study, but it's relatively the same. And what this allowed us to do is just kind of dial in specifically on certain measures and the way we were delivering it. So preterm piglets, each of these axes you see on the X, we go from an N6 dominant. So the, and this is the labels, from the study, but that's 100% soybean oil on the left, 100% fish oil on the right, and then you have kind of a mixed oil in the middle. And actually, Cynthia, the reason I included a blended in this study is because I think your papers were just coming out at the time where you were doing that. I was like, oh, got to add another group, see what's going on. So
yeah, the blending that was barely approved by the FDA, but we're able to squeeze it in.
That's great. So I recall very clearly, it was your papers that had me alter this protocol to make sure we had a blended. And so on the y-axis for each of these, the mole percent of that specific fatty acid. So if we look at linoleic acid, the top left panel there, kind of what we've been talking about. Your soybean oil is contributing to the LA. And as you go from more soybean oil to less, you see that decline in the overall rise in the LA. The red dotted line is the birth level. So they all kind of bump it up a little bit. But yes, the soybean oil dominant on the left is driving that. Let's go to the bottom right for DHA. As you would expect, as you have more DHA content, you're seeing that increase as you move more to omega-3 containing lipid emulsions. Here, at least at the time, was my surprise that if you look at the upper panel, the arachidonic acid, that even though you have slightly more content of that in the omega-3 containing lipid emulsions, you actually decline. You further go into deficit of arachidonic acid. And this is one of two concerns I have in this acceptance or this emergence, I would say, of using 4-oil lipid emulsions as a maintenance therapy. So I do think we're shifting, or as Cynthia said, there's interactions, we're shifting and having other fatty acids be impacted, and we got to think about, is that okay or not? And then on the bottom left is the EPA. And one thing, we haven't talked about it much. You even see in the red dotted line there where I had mentioned that it doesn't really change over, at birth and across time. But EPA is coupled in this fish oil with the DHA. I don't think right now we have processes by which we can separate the two right now. And that high EPA content is reflected in these levels, both in preterm piglets and infants. And that really is, as Cynthia said, an unknown risk about really substantially here, a 10-fold higher in what birth levels were. And then if you look at the N6 to N3 ratios, or even the ARA to DHA ratios, as you push towards the omega-3 containing fish oil containing lipid emulsions, you start to bring that ratio down, where at birth, here it was like 6 to 1 almost for the preterm piglet. In the human infant, it's like 2 to 3. But what you're starting to see is you're starting to reverse that ratio. And again, I think for arachidonic acid, we just have to remember the important biological effects. And is that something we want to do? Yeah, Cynthia.
Yeah, and I wanted to ask your thought, about, those of us that, like, a long time ago, we read and we're seeing all this omega-6 or linoleic acid as a pro-inflammatory versus the anti-inflammatory omega-3s. And does that apply to neonates in particular, to preterm babies? What are your thoughts on that?
Yeah, a couple. One is, I think we've inherited a lot of those thoughts from the adult literature. And I was not immune to that. When I was first sort of entering this, I was kind of thinking that way too. And one of my first animal experiments, where I was looking at these different ratios in fatty acids, I was anticipating that I was going to have a better outcome in these animal models as I pushed omega-3 and dampened omega-6. And in fact, I saw just the opposite. I saw in these early pup neonatal animal models the importance of arachidonic acid in organogenesis, not only in gut development, but in lung development. And that really went, wow, we really have to start rethinking about this in a very different way. My second thought would be I would be careful with the papers. And again, I've learned this over time, and I wasn't immune to these thoughts early on, but careful look at papers now where people automatically assume an inflammation profile when they see omega-6 derived products. For example, this prostaglandin or something is high. We are now seeing this pro-inflammatory environment. One thing we need to understand is a lot of those mediators that are even omega-6 derived are not pro-inflammatory, or it depends again on the context and the balance relative to each other. So I would be cautious unless it was specifically measured in some way of organ injury or other inflammatory profiles to immediately assign every omega-6 derived mediator as a pro-inflammatory mediator. So we have to be a little bit more precise, I think, with our language and our conclusions.
Yeah, and I think it's like you said, the timing, right? The time of the critical period of development that we're dealing with, and then the postnatal timing as well.
Yeah,
and we're going to see very much differences in the effects of this omega-6 and omega-3s.
And as usual, time flies when you're having great fun. Then we can go to the next slide, but the next slide basically reinforces those patterns in human infant study, just so you see that it is similar, where in blue is the fish oil containing lipid emulsion, and yellow is the dominant of a soybean oil. And you see this reduction in arachidonic acid and elevation in EPA. You do see an increase in DHA, but mind the axes and note that we don't reduce the deficit. And this is the other challenge. I had mentioned before, can we even prevent some of these deficits and replicate the secretion? That might be a challenge for us. Okay, next slide, please. So the 4-oil use compared to, now let's talk about olive oil. I saw someone in the chat ask about the use of olive oil lipid emulsion. In the general question, we saw that there was some. It looked like, I forgot what percent, but there was some. but that has been recently approved. And I think this is something we now need to consider in our armamentarium of what we provide to preterm infants. But what do we know when we compare it to a 4-oil? What happens to these overall levels? I want to make sure, Cynthia, we get to part 2. So I'm going to bump this because everyone got to the all of the above, and it is an all of the above. So let's go to the next slide. And here's a study that had that direct comparison. There's less of these direct comparisons than other studies, especially using intralipid, but data I think is coming out and accruing. And what you see in these panels, the upper left, arachidonic acid, at 7 days, there is a difference with the 4-oil being lower than the olive oil, but it kind of settles out later during the duration of the stay. You see that pattern of EPA being much higher in the 4-oil. The DHA, you do see that at the 4-oil at 7 days and a few time points after, being higher than what we see in the olive oil. And then the ARA to DHA ratio, because again, the interaction. So what's happening when you have this omega-3 centric or dominant? Well, when you're dropping ARA or even without doing so significantly, but really increasing your DHA, you're actually starting to reverse that omega-6 to omega-3 ratio or the AA to DHA ratio. And that's what we see in this study. I think the next slide is not published. It's kind of how I think about things. My kind of lipid report card, as you can see, there's no perfect grade here where everyone gets a nice green circle, which would be a desired effect. Let me explain this report card. This is relative to birth levels. How does the components on the left impact these fatty acid levels and these ratios relative to birth levels? If it maintains it, you get a nice green. If you go into deficit or excess, depending on the degree of deficit or excess, you get either a warning, kind of not so great yellow, or really don't like what I'm seeing red. So that's kind of the report card. So at soybean oil, we saw that tripling of LA, it's high. In some of the not clinical trials, because we've seen that data, but some of the single center studies, other studies, that high level can contribute to some of the morbidities. Arachidonic acid, we don't prevent the deficit, but the deficit is not as low as the fish oil containing lipid emulsions, hence the yellow. DHA deficit doesn't do anything to that deficit, a red, but it doesn't change your EPA, good. And it doesn't change the balance of ARA to DHA, good. It's still dominant in the ARA or omega-6 family. You go to the mixed oil, LA, less soybean, less increase. You get a good yellow there. Arachidonic acid, it actually sort of initially paradoxically brings it down. It's not paradoxically, I should have mentioned before, it's the EPA that might be impacting ARA levels. It comes down, gets a red. DHA does increase, doesn't reduce the deficit, but does increase relative to the others. That's a yellow, but substantially increases the EPA and reverses that ratio as we discussed. And then now the olive oil. Less soybean, less LA rice, you get that yellow. Arachidonic acid doesn't sacrifice it as we see as much as we see with the other lipid emulsion. DHA does no effect on the DHA, but like soybean oil, does not impact EPA or the ratio. So that's my kind of report card. Happy offline or later, we can talk about it further. I'm going to transfer you now, Cynthia. You drive and take us home, and hopefully we have enough time, but let's go
into a little bit more of the clinical part of the presentation. If you can show the next question. Again, do we know if a combination of soybean intravenous emulsion compared to the 4-oil increases the risk of ROP, BPD, PNAC, sepsis? What do we know, right? And I'm waiting for a few more, but we have a trend in there that is going to maybe none of the above. And what do we know? So I'm going to go to the next slide. I see that none of the above. That was the answer that that I was trying to allude. Again, the same, a Cochrane review. There's some small studies, plus minus, of different events. But as a prevention therapy, we really don't have any particular lipid emulsion that will prevent any of these disease processes. If you want to go to the next one, I'm actually going to go a little bit more into detail in the liver, right? Because that's what some of the studies that I've done, the graphs on the left are animal data. And what I want you to take you from today's presentation is more the importance of continuation of your lipid emulsion. Because on the left, I'm showing on the x-axis, it says that, it's preterm controls, those are fetal levels, preterm animals with intralipid emulsion, preterm animals that received no intralipid emulsion, and preterm or term controls and term 14-day animals. So what you see there is the levels of hyaluronic acid and the ELF scores. So those are novel markers of liver fibrosis that are used in older patients and adults. And what we're seeing is that the amount of hyaluronic acid is significantly increased when you're not providing any fat, intake into a preterm animal. And we don't see the same when we have, other animals at term, for example. And those ELF scores, we calculated those, and you can see that they're all like, yes, there's some differences in between the controls and the ones that did not receive or did receive some intralipid emulsions, but the numbers are very similar to the numbers on the ELF score that you see on the right. The graphs on the right, they're unpublished data. I'm working on it. It is over 100 patients that we were able to get, lab samples to determine and to do all of the measurements to determine that ELF score. And you're going to see there that line, that dashed line, is the level that is considered to be abnormal. Above that is abnormal and is a predictor of liver fibrosis in older children and adults. But see how high they are in healthy term and healthy preterm babies, and the same way at birth on babies that have high risk of developing liver disease. Once they start developing it's called PNAC or PNALD in there, but once they start developing some liver disease, they go higher, but they're all high. And as a contrast, you can see that the direct bilirubin levels are extremely low on all of the, healthy controls, and they're coming higher on the babies that are developing liver disease. So again, considering that we have novel markers to measure liver disease, they're all over the place. And the only way, we don't have a really good way of measuring liver fibrosis and an end product of liver disease currently, because you are only able to measure these in the lab. So I think a lot more that we need to understand on how to have a good marker for that liver disease. It's going to be extremely important to learn these exposures. But again, what we need to see there is that those animals that did not receive any lipid are the ones that had the worst liver markers of liver disease. And on the paper, we go over actual liver histology to prove that the liver fibrosis was occurring when there were no exposures to lipids. Next slide. The other thing that we looked at is the exposure to, like, only fish oil versus fish in combination with soy, and looking at lipid profiles, because we still have, like, very poor understanding of what does these early exposures translate into long-term health. These are babies that we follow for about 8 weeks of IV lipid exposures. So they were sick babies and they were prone to having PNAC. But we were trying to understand if the exposures would lead to differences in cholesterol or HDL, triglycerides in this short period of time. We did not find any differences in between the groups, but we did see that the levels of HDL compared to healthy newborns were lower, and the LDL and VLDL were higher. I translated them into graphs because in the paper is like a lot of numbers, but hopefully with all those numbers, they will serve as a baseline to look at long-term outcomes and also to do additional studies.
Cynthia, that's a great reminder about just lipids is such a vast class of important molecules, and fatty acids are just a part of that. And there's so much to learn from all of this. And think about, cholesterol and triglycerides, all of that forming the basis of cell membranes and myelin sheaths. And we got to pay attention to those lipids as well. So glad you're working on that.
Yeah, and don't get me started with the interaction with glucose metabolism, because we're going to have to extend to 5 o'clock so that we can learn a lot about insulin sensitivity and insulin signaling and their interactions with the lipid emulsions, right? And the long-term metabolic changes. And the next slide, please. So monitoring and other special uses, we get a lot of questions once in a while of, like, how do we monitor? What do we use for different types of disease processes? And we're going to go a little bit into that now. And next slide. So first, the essential fatty acid deficiency, right? We see a lot of these studies. That is a very, very common outcome measure that we have to go through that in order for us to get, for example, FDA approvals, or if we want to do long-term studies. Is it common? And is it common with the minimization, and at what dose, right? There was so many years ago that a lot of people then, felt that by exposing babies to lipids, we were causing liver disease. And that turned out not to be the case, but then we're causing perhaps more harm by doing that lipid minimization. And we're going to go a little bit of the history of how that happened and how did we get there. So I see that the majority knows that, the minimum to avoid that free fatty acid deficiency, it's 0.5 grams per kilo per day. And that is the correct answer. If you want to go into the next slide. We consider this deficiency from very early studies in the 70s and 80s, where it was more frequent on the late preterm babies that had RDS and that were not exposed to any lipids whatsoever. They can have clinical signs with scaly dermatitis, hair loss, poor wound healing, growth restriction, fatty liver. This is because the linoleic acid and omega-3s and omega-6, they're considered to be essential fatty acids in humans. So the recommendations have been there for a very long time. They seem very, very minimal. And I'm going to show you just a couple of studies that have, shaped this initial recommendations. If we go to the next slide. And I like going back to history of where did all of this came from, right? We're not going to be able to do these studies anymore because it will be completely unethical. But back in the 80s, they were, they studied this in about 60, I think it was 60, 70 preterm infants. They were born about like 31 weeks gestation. And they had 4 different groups because they were trying to figure out what is the best approach. Do we give lipids to these babies, like group 1, which the initial studies went from 0.5 per kilo per day up to 3 grams. Group 2 had just enteral feeds, but they were not maximized, and there was not a lot of enteral feeds, but no IV lipids were given. Group 3, they kept MPO and no lipids whatsoever because they had a lot of concerns about that contributing to the respiratory quotients and respiratory disease. And group 4 had no RDS and had enteral feeds. So I want you to see on the table on the right, the way they measure free fatty acid deficiency was by the trying to tetraene ratio and the percent of infants that develop this ratio greater than 0.2. And you can see there on the group 1 and 4 that received the minimum amount of like 0.5 per kilo per day daily. And in some of the cases were all the way to 3 grams. None of them had that abnormal trying to tetraene ratio. The same thing for group 4 because they were on enteral feeds. But group 3, which is the one that had no IV and no enteral lipids, 80% of them developed this free fatty acid deficiency by day of life 7. So it is very important for us to remind ourselves we have a lot of unknowns, and we should not be afraid of providing, good IV nutrition for these infants. And we should provide enough nutrients to get them to grow until we know better of all the different interactions. So we do not go back to, the 80s when we were, not given enough and causing this free fatty acid deficiency.
And Cynthia, there was a great question in the chat with the previous question where it was 0.5 was the answer, grams per kilo per day. Wondering if this was assuming the interlipid or soybean content and how that might be different with other lipid emulsions. You might be going into that a little bit more going forward, but that was a question.
Yes, so I think this was with the studies. This is one of the hallmark studies back in the the babies were enrolled in the 80s, and they were primarily soybean-based lipid emulsions. That's what we use. We do not know with the new lipid emulsions, and then I'm going to go into that a little more on how to monitor and how to really assess this essential fatty acid deficiency with the newer products and with newer testing.
Perfect.
We can go to the next slide. And this is where we're going to go into the Holman Index. And is that the only test that we need to be able to diagnose free fatty acid deficiency? And this is something that is extremely important because even though we don't use it as much in clinical practice, we use it 100% of the times on any study that we're doing IV lipid studies that have to go through the approval of the FDA. The FDA is really key on determining this free fatty acid deficiency. And in any of the studies that I have reviewed or that I have been part of, that is very much one of the indices that it's utilized. So it is false. And then we can go into the next slide. So again, a little bit of history. We're going back to the 80s, one of my favorite eras, of course, not for nutrition, for fashion probably. So this essential fatty acid deficiency, what they saw, it was premature infants, 28 to 29 weekers. And what they looked at was the level, as the level of plasma linoleic acid increased, which is the line that is continuous, right? Initially, it was low on the 8, this is the first week of life on the x-axis is 0 to 6 days. You see how it's kind of like flat, right? And as it's low, that level is low because in those babies that were not receiving much feeds or IV lipids, then the trying to tetraene ratio was increasing. And you see that on the dash line that has the asterisk in it, the one that is going up. So the level that was considered to be high was about 0.2. This was initially based on term babies, and the trying to tetraene ratio. What we have to really think about is a colorimetric test. So it depends on the changes and the chemical change that you achieve when you expose that blood to a certain chemical that provides you that change on the number of bonds that you have. So it is to me that is more of a subjective, because it is a ratio of something that you're not accurately measuring, and it's something that for a long time it really has made a big difference in a lot of the studies. But now that we have an advantage of being able to do more measurements, and I'll show you with the next slide. If you can go to the next slide. This one is just showing you the differences in the plasma levels of the linoleic acid, which is what is part of that Holman index, and how that goes up as you have less days without feeds. If you go to the next slide, I believe that's the one that, so this is the one where I want to show you that ratio, right? As the mean acid increases, which is that trying to tetraene ratio, then that is going to give you the diagnosis of free fatty acid deficiency. But now that we have more and more preterm infants and smaller infants, and there's a lot of interactions, and we've seen that, right, Cami, in our studies, how the mean acid all of a sudden is higher and it's an omega-9, but all of the other ones are high, but not as high, and that ratio gets off. That doesn't mean that this baby has a free fatty acid deficiency. And now we're learning, and what I think that the future will bring is that the additional studies that we're doing these measurements, right? All of us should be making now these measurements when we're doing prospective randomized controlled trials. But also we should be looking at the polymorphisms of the liver disease processes that can alter these different levels, because we have seen now that having polymorphisms will give us a difference in the ratios, and will also give us a difference in the amounts and the levels of omega-6 and omega-9s and omega-3s fatty acids. And that could be something that for long-term, right, precision medicine, it will be very helpful for us to know all of these additional details.
So glad you brought that up. That is exactly right. I think us starting to also interface with the genetics of the metabolism, and those SNPs and polymorphisms definitely play a role. They're not as uncommon as you think in some of these cohort studies, and we need to understand that as well. So that was a great point.
Yeah. So we have a couple of minutes left. If we want to go to the next slide, please. So again, the fatty acid composition, look at it, look at your different linoleic acid measurements. If you want to click next, where I'm highlighting there, we're not just looking at the amount of phytosterols, the amount of vitamin E, we're looking at the amounts of other components, right? And how, they're different depending on the solutions. but we don't know which ones will give you the better interaction compared to, what the needs are at that particular moment. But then that will determine your trying to tetraene ratio as well. And then, so you may see, if you go to the next slide, I will just ask, I think this is the last couple of questions that we have. The following ILE solutions are approved as a nutritional supplement for cholestasis in patients with intestinal failure associated liver disease. And you can see, and this is something that, as we continue to practice, then we know that, we all have those patients that have cholestasis. And as they develop the cholestasis later in time, then we utilize fish oil-based lipid emulsions. And we have all seen the next slide. So the answer was none of the above. But I'm not saying that we shouldn't be using IV fish oil for cholestasis, okay? What I'm saying is that the indication in the label by the FDA is that omega-3 is indicated as a source of calories and fatty acid in pediatric patients with parenteral nutrition-associated cholestasis, but is not indicated for the prevention of this disease. And also the indications for all other IV lipid emulsions as a source of calorie. So omega-3 is the only one that is specifically indicated as the source of calorie if you have cholestasis. Again, but not as a prevention therapy early on. But once the cholestasis is established, we all have, used omega-3, and we have seen some of the results that others have seen, which is shown in the next slide. Again, I think that I already talked about, not for prevention, but for later in reducing that unbound bilirubin level. If you want to go to the next slide. So this is what, we all have seen, this early reports and many different reports after that of, reversing cholestasis, again, over a shorter period of time. But again, I still have concerns that does that reverse the liver fibrosis that we don't see, and we don't have very good markers in neonates. What we do have, and this is another paper from the same group from Boston in the animal model, where they saw that hepatic liver fatty infiltrates was not there, or was very minimal on the animals that received the normal feeding. But if you did not have any lipids, which is the next bar, which is the HCD alone, that they do not receive any intralipids, that's when you have the highest amount of lipid infiltrates in the liver, meaning not giving lipids is not good. The type of lipid is still in debate, but the one that can probably reverse cholestasis so far has been fish oil alone in a lot of prospective cohorts. If you want to show the next. And we have published some of the long-term outcomes of using fish oil alone. And we did a prospective study comparing with matched controls with long-term neurodevelopment, and by utilizing fish oil in combination with intralipid or IV, and I'm going to talk about it just because it's in the paper, that was a soybean-based solution in combination with fish oil. But at some point, it was fish oil alone. We had matched controls. They achieved the same cognitive, language, and motor outcomes when they were matched at 6 months and at 12 months of age. If you want to go to the next one. Which statement is true regarding the compatibility of different emulsions? And I'm going to wait and see, soy is incompatible with benzodiazepines, or the 4-oil is compatible with meropenem. it started moving. So then I was reading it, but you can read them. And they are compatible with amino acid solutions at multiple concentrations, regardless of the gestational age. And I think, a lot of people is, going through them right now. But we can just probably, I'm trying to see how many more questions I have, but I think it's
two quick ones after this.
Two quick ones, right?
Two quick ones.
So sounds good. So this one is correct. You guys guessed correctly. It's compatible with all amino acid solutions, regardless of the gestational age. The main point I wanted to make, and if you want to go to the next slide, it was just ask that question, right? The medication compatibility, you have to go to the studies that each company has done on their own to be able to see if there's enough data that you can have them both combined. And I mentioned all the different, products just because some have done more testing with benzos, some have done, they didn't. Meropenem has been a problem. So just pay attention as you're using different emulsions on what that insert says. And then the true or false, it's, the medication compatibility data is all the same. We already talked about it. It is false. You want to go to the next one. And a new solution has recently been approved for pediatric indications in the US. And I think somebody had a question about that in, I think I saw it flying in the chat. And if you want to go to the next one, that is true. And this is more of like, the emulsions that have been available in the US have been, for a long period of time, as you can see initially in the 90s, right? We only had one available versus during that time in Europe, they've been like, they've had like 3 or 4 different available solutions for a long time. So we're a little behind on the approval, but the new solution with olive oil and soy was recently approved in 2024 by the FDA. And some people start thinking like, well, do we really need another type of solution? For me, the answer is yes, because we don't have enough data on what is the best combination, and then we can continue to build on the report card for Cami, depending on the period of development, right? The disease process, the length of therapy, and we need to be careful about the long-term health and the long-term implications of all of these solutions. We were one of the sites for getting the approval for this olive oil solution in the United States. And we are in the process of publication. We enrolled over 100 babies in the United States, and 90% of them were premature infants. And we have free fatty acid profiles, and we learned a lot on, on this cohort of patients that prospectively, we did a comparison head to head. And we learned also about polymorphisms and developing some of that liver disease. So you're going to see those results pretty soon.
Yeah, that's great. And just to reiterate that it is important to continue to evolve in what is available to us and to understand it to the degree that Cynthia was talking about. But also, and it was a question in the chat, which was terrific, is how do we actually start to think about the combination of our nutritional strategies where we use lipid emulsions and we're driving it in some perspective. If we can't make 100% correction, are there additional enteral strategies that we can couple with that as these enteral options are also emerging? That helps us do that in even a more efficient manner. So definitely important to continue to iterate on both ends.
All right. Well, thank you, Cynthia and Cami. This was an incredible presentation, and we probably needed a 3-part series for all this information. but it was really amazing. So thank you. I've been keeping an eye on the Q&A, and I think, having the questions come in throughout was good. But if anyone has any questions now, we're happy to take a couple of questions. You can put them in the Q&A.
Yeah, we both tried to monitor it and answer it when we weren't speaking. So I was able to answer a few, but if there's some that we missed, please either re-enter or let us know in some way. Happy to answer.
And just a reminder to complete your survey, you can scan the QR code, and that really does help us for future programs to identify, gaps in education. So we appreciate you taking the time to complete the survey as well.
And thank you, everybody, for taking time during your lunch hour to join us.
Yeah, no, it was fantastic. And thanks for the engagement and the active chat. Appreciate it.
I'm trying to catch up on the questions since a lot of the questions came later.
Okay, there's a question in the chat that says, what should be the ILE strategy in acute neck?
Good question. Do we have data on that? We don't. And and there was a recent review and a pending commentary on this subject in pediatric research that you might have seen the original paper in a group of people trying to answer nutrition during and after necrotizing enterocolitis. And I know there's going to be a pending commentary on that coming soon. I just don't know if we have enough information on that, but it's an important question because this is where the sort of efforts where you have two different opposing goals. You have one goal of reducing the inflammatory component that might be leading to ongoing intestinal injury, but yet you need to support repair and tissue repair. So it may be, yes, the omega-3s are important in sort of suppressing that inflammation, but as we've learned in some of the studies, including with the gut and gut injury models, that it's the omega-6 metabolites and driving that tissue repair. And so how do you blend that? And maybe it's you phase it in and out. Hopefully we get smart one day where we understand during the course and evolution of the disease that you may change strategies in that short period of time over the evolution of the disease. But those are the very questions that I think are important as we move forward and then we have more options. How do we tailor it to the individual baby and what the baby is experiencing?
Mm-hmm. Yes, and that's why, in some of that data with the preterm babies that we published, you're going to see, we had a lot of concerns about taking away completely that omega-6 component, right? And then so we continued that as we added, fish oil and, using a combination and a blend for a period of time will probably be the answer. And just so then we can support that repair.
Yeah.
There is a question about the neonatal patients that have limited line access and compatibility issues when choosing a lipid agent. I can probably say that a lot of the times we want to, of course, maximize everything and put it on the, the central lines. But if we are running into trouble and you have a good peripheral line, remember that you can give your lipid emulsion through your peripheral line as well. And I think sometimes we forget about that. I think there's also a lot of concerns with some of the emulsions and that we just don't know yet. And there's not enough compatibility published in it, that then we decide to remove it just in case. But I don't know what your experience is, Cami, but in a lot of our studies, we really have not found that to be a major issue, even when we didn't have that many lines.
Yeah, no, agree. Same.
Yeah, and I think the point that you made earlier, Cynthia, excuse me, about checking with the manufacturer about the testing. And because I think, manufacturers have done more extensive testing with medications, and that information is becoming more available. And so, we hear of people having to hold lipids and the babies aren't growing. And so just checking and with any of the manufacturers for the lipids, because that research is there for a lot of the medications.
Yeah, or sometimes it gets extrapolated, right, from one to the other. Or like you read the manufacturer's indication or contraindications, but you have to really be careful and look into the contraindication was a real contraindication or a warning, because there's no studies, right? If there's no data in regards to incompatibility, then in general, I'm like, well, there's no data. We don't know it. We've been using it for so many years along with all these other products that we're probably going to continue to use it for now in order for us to give IV nutrition for this baby.
Yeah, that comes down to your clinical judgment, and but always feel free to call medical affairs or med info and see if that information is available. But I would like to thank everyone who stayed over, and thank both of you for giving us so much great information. And we will go ahead and close the webinar at this time. Thank you.
Thank you, everybody.
Thank you. Bye-bye.
Bye-bye.